I am an orientation and mobility specialist.
I'm a lawyer.
I'm a firefighter.
I'm an advocate.
I'm a sister.
I am a mother.
I'm a friend.
I am me.
I have bipolar disorder.
Depression.
On borderline personality.
I'm not embarrassed.
1 out of 5 people lives with a mental health condition.
We're all people, and if we talk about it, there's hope.
Good afternoon, everyone. My name is Christopher Ramnauth, Community Engagement and Partnership Coordinator at VA Western New York. This event is hosted by the Anti-Stigma Coalition, and I will be your moderator today as we explore the topic, Healing Beyond Trauma, Understanding PTSD and Overcoming Stigma. But before I introduce our panelists and get started, as always, I want to acknowledge that this could be a difficult topic. So if you need to take a break at any time, please take a break. If you need immediate resources, you can call the 988 Suicide and Crisis Lifeline. Or if you're a veteran or service member, you can call 988, then press 1 to connect with the Veterans Crisis Line. So our program is approximately 1 hour long. During this time, if you have any questions or comments, please type it in the comment section. Now, it gives me great pleasure to introduce our panelists. First, we have Cindy Goss, President of Catch a Falling Star Law Enforcement Assistance Program. Thank you, Cindy. Next, we have Eric Krupczyk, Peer Support Specialist at VA Western New York Healthcare System in the PTSD program. Thank you, Eric.
Nice to be here, thank
And
you.
lastly, we have Tammy Kling, owner and founder of Clear Skies Counseling. Thank you, Tammy. So you guys ready? So my first question is, can you all provide a brief introduction about your role and work in the community? And I'm going to start with Cindy.
I don't know if anyone can hear me. I don't have any sound. I'm so sorry.
Good afternoon. I appreciate this time to be with you. My name is Cindy Goss, and I've worked in the community for about 30 years as employee assistance professional, a private practitioner. The majority of my work I work with first responders, military veterans, and coordinate, assess case management and trauma response.
Thank you, Cindy. I'm going to go over to Eric.
Hey, how you doing? My name's Eric. I work at the Batavia VA PTSD clinic, and I worked outpatient prior to this in the community. And we basically just work with veterans with either combat trauma, MST, childhood trauma, basically any kind of PTSD, depression, anxiety, substance use. And so we work on that here, and our buildings are split between male and female. It's one of the few programs in the VA that is able to isolate and have both sides have their own place. So that's what we do here.
Thank you, Eric. I'm lucky enough to have Eric as a colleague, so thank you. Tammy, can you hear us? Just wanted to check in.
I can. I'm so sorry. I had to exit and come back in.
No worries. It's a live show. No worries. So the question I had for all of the panelists, and you're up next, is can you provide a brief introduction about your role and work in the community?
Yes, I am Tammy Kling. I'm a clinical social worker. I've worked in the field for about almost 25 years now. I have a private practice where I do a lot of work with PTSD, trauma, anxiety, depression, whatever someone might bring to the table. I do a trauma treatment known as EMDR, which can help with post-traumatic stress disorder, lessening those symptoms, desensitizing triggers, etc.
Thank you, Tammy. So we clearly have a panel of individuals who have great experience in our community. So again, I thank you all for joining us here today. So my next question, though, is what types of experiences or events can lead to PTSD? What are some of the common signs and symptoms of PTSD that people should be aware of? And I'm going to start with Eric.
So PTSD can develop after any actual or threatened death, serious injury, sexual violence, military combat, obviously, military sexual trauma, physical or sexual assault, serious accidents that you get into, any kind of sudden loss, childhood abuse, domestic violence. I mean, the list is pretty pretty extensive, right? And the symptoms are kind of wide ranging. I know for the people I work with, the population I work with, intrusive thoughts and memories, nightmares, avoidance, basically any negative change in their mood or behavior that is lasting, right? Increased hypervigilance is another big one that we deal with a lot, especially when we take vets out on outside outings. That's a pretty big one. Poor sleep, being easily startled, constantly on guard again. So that's typically what I see here where I work with our patients.
Yeah, absolutely. How about you, Tammy? What are you seeing in your private practice?
So I have a niche in my practice around recovery from narcissistic abuse. And that's kind of my market. So people are looking for counseling specifically around that a lot of times. So that's the biggest thing people come to me with. So we work on most of the same symptoms, hypervigilance, difficulty in relationships in the future after suffering from abuse in a past relationship, whether that was family, partner, sometimes even in work situations. So we work on desensitizing those triggers, ability to trust again. People often struggle in trusting others in any capacity after suffering abuse. So as I mentioned earlier, we do a lot of EMDR to desensitize triggers and symptoms people are having. Not that we can erase any memories at all, but desensitizing those triggers, knowing how to better navigate and feel more comfortable in future situations.
Absolutely. How about you, Cindy? How about in your work with law enforcement?
Well, if you look at anybody is in a first responder position, being open disclosures isn't a part of their role. And so they're taught from day one not to talk, not to communicate, not to share emotions, weakness, etc. And that's the stigma of their role because they're supposed to be strong, indispensable, nobody can hurt them. And oftentimes, if you don't have it started beginning at their academies, explaining some of these things and educating them, the worst time to be involved in a critical incident is when you're right in it. Most of them don't understand what's happening to them. They just know they're traumatized. They're not sleeping. They're not eating. They still have to work. They still have to do paperwork and reports. And oftentimes, they don't even understand what's happening to them. They don't realize they are slowly moving into that direction because it's not something that happens immediately. You have post-trauma, as Tammy was talking about, that without intervention, without treatment, can then turn into the PTSD. So that's why we do our interventions to help explain and educate them so that it doesn't end up ending their careers or their families or their children's relationships. So that early intervention is really important, that we get them to people like Tammy and the resources that we have available.
And you're all bringing unique perspectives, not only with the work that you're doing in the community, but even symptoms and signs that you're all seeing as well. So if anyone is just joining us, again, my name is Christopher Ramnauth. I work at VA Western New York as your Community Engagement and Partnership Coordinator, and I'm your moderator today. And I'm joined by Cindy Goss, Krupczyk, Tammy Kling, as we explore the topic, Healing Beyond Trauma, Understanding PTSD, and Overcoming Stigma. So my next question for all of you is, how can we broaden the public's understanding of who can experience PTSD? I'm going to start with Tammy.
Well, some of the things that were said earlier about understanding PTSD can come from many, many sources, whether that's combat, serious injury, witnessing something violent, significant losses, multiple losses at one time, suffering abuse, and understanding that it can affect anybody of any age as well. And one thing I think that's not well known is trauma is not actually defined by the event itself. It's defined by how it affects the individual. Something terrible might happen, or something is experienced by one individual that causes a lot of concerns and things that affect the rest of their life, and other may not be as affected. So it's really in how the incident affects an individual.
Absolutely. How about you, Cindy?
100% agreed, because everybody responds differently. Their journey is different. And unfortunately, they don't really realize sometimes what's happening. Because when I teach in the academies, I teach whatever we don't work out as human beings, we act out. And that acting out comes in our emotions and our behaviors. So they start having issues at home, possibly at work, with the families. They're talking, they're not talking. They're depressed, they're anxious. They get a little bit boisterous, louder and louder when they're responding to their loved ones. And they don't really see this. They know what's happening, and oftentimes feel they're going crazy until we actually give them a diagnosis. And not only sharing with them what is happening, but this is what you need to do to treat this, because it may not be your fault that you were exposed to a traumatic event, but it's also your responsibility to accept the treatment for it. And most people, aren't receptive because of the stigma. What if there's something wrong with me? And those are the folks that we end up losing, because they either deny access to treatment, and unfortunately sometimes takes a critical incident or a bad incident at home that kind of wakes them up a little bit, that no, you do need help.
Well, that's well said, Cindy. How about you, Eric? So how can we broaden the public's understanding of who can experience PTSD? What do you think?
I think there's a couple different ways, at least in my experience with going from the civilian populace into the VA and working with veterans. I would like to see eventually everybody move away from this idea that PTSD is only with veterans or combat vets. Like, it's almost like it feels like they have a little bit of like a monopoly on that term. And so I think too, with the stigma that's surrounded by that, people really don't even want to hear that a lot of times, and like, that's like just something they kind of avoid, or at least in my experience. And it's, kind of moving away from that, and then letting everybody know that it's like, this is something that anybody can have for any number of reasons. And again, I'm moving away from that stigma, trying to make it so that it's not the end of the world to get that kind of a diagnosis, right, or to deal with that. And, I agree with what you were saying just before me, is like, a lot of people know that this is happening in themselves, but it's hard to deal with. It's hard to come to terms with. And I think a lot of times too, it's hard for family members to bring that up, and they don't want to put that on you. You know what I mean? Like, they don't, it's hard to tell someone that it's like, hey, I think you have this and you might need to get some help. Not only because it's a difficult conversation, but for the reaction that they could have to it. So I think just getting more information out there and widening the scope of what people think PTSD is would be helpful.
Yeah. And I think we, and you all did an amazing job right now setting the foundation of what PTSD is. But, and many of you have already answered these questions, but I'm gonna put this out there anyway. So how is PTSD diagnosed exactly? And also, what are some effective treatments and supports available for PTSD today? And if you want to also mention some local Western New York resources as well, I think that'd be great for our listeners. So again, how is PTSD exactly diagnosed? And what are some effective treatments and supports that are available for PTSD today? So I'm going to start with Cindy for that.
Once we work with an individual and we suspect, because a lot of the work that I do is I assess and refer, and then case management, making sure they're doing what they need to do. So my goal is to identify the appropriate resources, the culturally sensitive folks that also have worked with first responders and military veterans, because they relate a lot differently. If you've never been exposed to them, they tend to kind of pick us. We don't pick them. But folks like Tammy, for example, would do the assessment and then make the diagnosis and then provide treatment. So we use those professionals in our community, whether it's Horizons, private practice, or with Eric, that the appropriate people are diagnosed. Then what's the treatment? And then the treatment then includes the appropriate referral sources. Does somebody need substance abuse counseling because they're now self-medicating? Does somebody need marriage counseling because I've just destroyed my marriage because I throw things through the wall and I don't understand what's going on with me? So both residential, there are programs that we use locally and out of state that have specialized resources for trauma and PTSD and so forth. So we utilize those as well as those outpatient resources within our own community.
When you were talking, Cindy, this idea of a collaborative. It very much is a collaborative amongst these different providers and resources in the community. How about you, Tammy?
So in the clinical setting, whether it's private practice or a clinic, we have to follow the criteria that's outlined in our DSM, which is the Bible of mental health diagnoses, and certain criteria have to be met, et cetera, especially when insurance is involved. So there's certain criteria, which much of it has been mentioned here already: hypervigilance, always feeling on edge, difficulty in relationships, non-trusting of others, and all of that. So to fit that diagnosis of PTSD, we kind of have to check the boxes on paper, right? But I have found, even if someone doesn't necessarily fit that nice, neat little box of PTSD, there's generalized anxiety, there's unspecified anxiety. Some of these issues and concerns and difficulties someone has are still there, even if it doesn't necessarily check all those boxes of PTSD itself. So that's kind of what I look at first, because unfortunately I'm kind of bound by those requirements there. But again, my approach is meeting somebody where they're at. What are they bringing in? What are they expressing they're feeling right now? Then assessing their history. What has the history been? And kind of helping them kind of untangle their past, if you will, of different experiences they've had, and kind of going from there. And again, I do a lot of the EMDR, which is eye movement desensitization, and reprocessing of these traumatic events and after effects of it. And my coin phrase, I joke around with people and say, you can EMDR anything. Insurance companies may not agree, but that's my approach.
Thank you, Tammy. How about you, Eric?
Very similar to Tammy. I mean, here we're kind of bonded to, clinical assessments. Well, the DSM-5, we have to follow that pretty closely. We use CAPS-5 and PCLs, and we get all sorts of different assessments that we give people. And really, it just kind of looks at your trauma exposure, your symptoms, how long these symptoms have been affecting you, and what impact have they had on your life. And so, we're, like I said, we're kind of stuck to that. And I think the clinicians here do a really great job of being able to get that out. Sometimes it's difficult to pull that stuff out of people, even getting them to share what it is. Because I'm in a PTSD clinic through the VA, we typically get people that already have the diagnosis here. And so we know that they're coming with that. And sometimes there's some reluctance on sharing information on that. So we start by asking, normal, simple things, or looking at what is causing your avoidance, what's causing your sleep issues, what's going on with your relationships, what brought you in here, right? You came here, you're seeking help. So what is it that it wasn't going right that you ended up coming here, taking time out of your life to be in an inpatient clinic? So, and just try to kind of build trust and get that relationship going and that rapport built.
No, absolutely. I think that makes sense, Sarah, for sure. So there is a question from the chat that I want to put out to all of you. So this person says they have not experienced first-line medical personnel that assess for PTSD, but they've seen depression and anxiety screenings, which may be symptoms, but not specifically for PTSD. Have you all seen something that's being used out there with medical personnel in terms of screening? I think, Tammy, you may have mentioned it, right? In terms of screening?
Medical personnel such as primary doctors or
I think the question was for, it sounds to me, if I'm interpreting correctly, that yeah, doctors, physicians, hospital members, clinicians.
I'm not sure. I can't speak to what the practice is with primary doctors or other medical personnel. It certainly should be a thing. I know some primary providers do the depression and anxiety assessments, such as PHQ-9, GAD-7 for generalized anxiety disorder. It certainly should be looked at and assessed for sure. And, referrals made accordingly.
Yeah,
I can't speak to what they actually do or not do, aside from I know some do depression and anxiety inventories.
Right.
And it looks like the confirmation from the question was primary doctors, but thank you though for that, Tammy. How about you, Cindy? I think you were gonna add to that.
Yeah, I was just going to share what Tammy had said. Oftentimes I get folks that come to me, and unfortunately they're always in crisis when they finally come to me. And now we have to try to figure out how to clean up this mess. And oftentimes they may be diagnosed and or treated for symptoms by a primary doctor. If it's somebody that just is having bouts of depression, sometimes it is effective. But unless you really do the actual screening and look at the criteria, a primary doctor is prescribing medication for a virus and for this and for that. But oftentimes, if they're not on the appropriate medications and or the appropriate dosages with someone who does this, like Tammy has resources, I have resources, and so does Eric, they can really look at. There's genetic testing they can look at doing to find out what medications are going to work better with you and what with your, medications don't. So sometimes we may transition them to a therapist and a resource that can prescribe medications. And it's never a quick fix. It's that one medication or a combination that works for that particular person that is going to be helpful with minimizing the side effects as much as possible.
Okay. So what I'm hearing, the conversation can start with a primary care physician, but likely then it's going to go into those resources and connections that you all spoke about. How about you, Eric? Was there anything that you wanted to add about that other question as well?
Not too much. It's the same process for us.
Yeah.
That they come in, whether it's, they're seeing a primary care, nursing, basically whoever. Our hope is that, whoever they're working with realizes what's going on. They do, like I think you mentioned the GAD and PHQ, like things like that, and those assessments, and then looking at symptom clusters, and then trying to get people in for further care. Because I think Cindy, you were right. Like it does sometimes just start with, I think I'm depressed, or I think I'm having a lot of anxiety, or I'm having trouble with this issue or that, and then just kind of moving them in so that we can broaden the scope, look at everything together, and then go forward from there.
Also, if I might add, I think medication is great, but people often hope that the medication is going to be the be all end all, and often that's not the case. That has to be coupled with therapy, coupled with somatic work, meaning things to help get that trauma that we store in our bodies and our muscles and out of our bodies. And that's where things like EMDR can come in, even massage therapy, acupuncture, those more holistic approaches also. And just simply talking about your life and the things that have affected it, which people often shy away from because they don't want to talk about those uncomfortable topics and things like that. But it really helps to get that out coupled with the medication. Medication often is something that can help, level out the symptoms in order to address it in those other ways as well.
And you have to look at that. Not everybody is upfront and honest with their primary doctors. Not sometimes even with their therapists, that they're not sharing, okay, when I was 10, I was sexually abused. Or because they're not great disclosures. And so sometimes a primary doctor is just working on just what they're being told. And so sometimes we find out afterwards, did you share this? Well, no. And so then we make sure everybody who's in that team, that they're all on the same page. They all know what's going on. We can't hide this anymore. And my word, like you say yours is how's it working for you? Well, it's not. Well, I have some options. I have some suggestions. Would you? And how we address that is non-judgmental, non-criticizing, making them feel comfortable. You are okay. You're going to be okay. You are normal. You're not crazy. What's happening isn't wrong. It's not working. Let's look at what we can do to find what will work for you, because you may have family members saying you're a loser, you won't go to your job, you're nothing but a drunk, all you're doing is taking your anxiety medications, and they're doing the best they can to survive. Sometimes the interventions that we do are not only helpful for the person, but also the family members that need the education.
Right.
How should they react? How do, we're not justifying their behavior, but we're helping to explain so you get a better idea. While they work on their stuff, you get a better idea that this isn't a bad person. They're trying to survive like the rest of them. And these are his survival skills right now. We're going to teach him new skills, new coping skills, to help reintegrate that family back together.
Yeah. And, as you say, this idea of family and, even this idea of telling your story kind of made me think of some of these other questions. So I'm going to skip down below to some other questions here. And I want to put this out to the group of how can storytelling and lived experience help change some of those public attitudes that we talked about? So again, how can storytelling and lived experience help change public attitudes? And I'm going to start with Eric for that.
I think storytelling and being able to identify with people makes a huge difference. I mean, that is basically the entire premise of my job here, right? I'm a veteran that has PTSD. I've gone through these programs. I've used the different interventions and have worked with numerous different, clinical psychologists, social workers on kind of how did I move through and come out the other side, right? Essentially just sharing my story that's like, hey, I have living proof right in front of you that this can be done. It's not a permanent thing. It doesn't have to be, life ending for people. And it's, essentially for me, it's my job is to be the bridge between, the person seeking treatment and the people providing it. And I think storytelling is really great because it allows you to identify with the person you're working with, kind of get on level ground with them. I do understand what it's like to go through that. I do understand what it's like to lose loved ones. I understand, the after effects of being in combat. And it kind of, I think it really helps to get people to open up and share when they can identify. A lot of people really do struggle to get those things out, or they're things that they've covered up, or even we've seen sometimes where people have one trauma and they don't want to talk about it, so they bring up a lesser trauma in an attempt to kind of work towards that bigger thing. We see that a lot with people that have childhood sexual trauma or military sexual trauma. It's like, I'll talk about my combat experience, but I don't really want to get into the MST yet. And they may not, on their first run through here, and that's okay. But being able to tell your story and identify it gives them I think a place of comfort, to know that they're not alone, they're not the only ones, and that there is help for this. And if you follow and do the things that they're asking, it can be super effective. So.
Yeah. Those words matter is what I'm hearing. How about you, Tammy?
I think everything Eric said was spot on, and people just want to be heard, right? Even if they're talking to, someone who's not in the field or not a professional, they just want to be heard and have that support behind them, even if the person they're talking to doesn't really understand what they've gone through. Just being that person they can feel emotionally safe with. And that's, I think, a barrier in a lot of different dynamics and relationships, family and otherwise. Support groups is a great place for people to be able to also tell their story and feel safe and know, wow, yeah, I'm not alone. And, be able to feel more comfortable with opening up and also offering their support to others who are there feeling alone and on an island. And often people's traumas are unfortunately more common than they realize.
Yeah. And how about, thank you, Tammy. And how about you, Cindy?
Everybody is pretty much on target working in this group. One of the things that we like to access is we do trainings for peer support. And it pretty reminisces exactly what Eric and Tammy have said. Somebody who understands that cultural sensitivity, whether it's a Marine or if it's a firefighter or a correctional officer, because the first thing they may say is, you don't know what it's like. You've not walked in my shoes. And I don't know what it's like, but I know what it's like, what happens to you if you don't accept help after an incident that happens. So the peer support we do, we put them through training, and that's exactly what it is, peer support, not counseling. But then they can relate to one another and speak with one another. And even if they choose not to speak at, say, a debriefing, we like to, within a 48, 72-hour period, offer a stress debriefing because it's fresh. It's there. It's right in front of them. And then make the referral afterwards if necessary. And if they don't have that opportunity, we debrief people from Vietnam. But it's much harder, especially for people who are doing the assessment and the treatment of EMDR. The purpose of the EMDR is trying to get into that brain where we put it and hide it, where we don't want to share it. It's a lot easier through the EMD process to be able to get into that slowly, piece by piece by piece. And like Eric had mentioned about what are they willing to bring up, and it's their recovery. We had a treatment program that we had people show up, and we had a veteran. We have a high contingency of veterans in law enforcement, especially corrections in New York State. And he's a real big guy, real tough guy. And he said to the therapist, well, tell me, how does this work? He said, I got my stuff from home, my life, my childhood. I was in the service and I was deployed twice, and now I'm in corrections. And she said, well, first we're going to do the first layer, which is you. And then we're going to get to the second layer, which is the stuff from the Army. And then the third layer would be, how are you triggered from your job in corrections? And it's layers. It's layers. And people who do the EMDR work very, very hard and diligently, because sometimes you'll find that it's not that trauma that is the issue. It may be how we responded to that trauma. Sometimes they can get hurt more by, say, a department not responding appropriately that hurt them more. And then you have a lot of walking wounded because of how we respond to them. Suck it up. It's not a problem. Oh, that was 20 years ago. And these walking wounded walk in silence. And these walking wounded with the PTSD are at higher rates of suicide. And so how do you tell that to somebody who's in such pain and have been through therapists and medication and all of the other interventions, and they're just tired. They're just tired. So the preventative that we try to make sure we do the best we can, we're not perfect, is to help them understand at the beginning. And the more they're educated, they'll say, I have people call me after years being in the academy and they'll say, I remember what you said, Cindy. Untreated critical incidents can turn into this, and I think I have this. I'm like, well, let's find out. And it doesn't matter. Let's get you where you need to be. But sometimes you lay that groundwork, like in the academy, they're taught, this is how you shoot, this is how you wrestle people, this is how you take them down. But nobody's telling them what happens afterwards when there's 3 dead bodies and you're having these nightmares.
Mhm.
You know, because they're not going to tell their partner because they're going to think they're crazy. But in an intervention that we do post, everybody can hear that everybody in that room was affected. And if you don't speak, it doesn't mean you're not listening. You're not hearing like, okay, I'm not the only crazy person sitting here, as we try to normalize this incident that they just went through.
Yeah. And your perspective, and all of your perspectives, are so unique in this work and what you're seeing. I do want to acknowledge there are a lot of amazing questions coming in through the chat, and we're going to try to get to some and weave some of them in. But I do want to ask this one question to all of you. When you hear the word stigma in relation to PTSD, what comes to mind? So I'm going to start with Tammy.
Well, what comes to mind is often what people say, quote unquote, just get over it. Or that was, like Cindy was saying, that was 20 years ago. Why aren't you past that? You know, why is that still, you know, bothering you? Or, you know, the stigma is just, you know, we have to have that rough exterior and nerves of steel and, you know, feelings aren't okay and, you know, things like that. And whatever front we're talking about, like we said earlier, there's all kinds of different traumas. And I think that's also, the stigma is one's definition of what as I was saying earlier, of trauma might be different than someone else. And someone's saying, you know, what's the problem? And then also I kind of wanted to piggyback what Cindy was saying earlier about the re-traumatization of individuals that do come forward and want to address it and talk about it, and how they're received or not received, or how they're interacted with the systemic problems of, you know, in my case, I see a lot of domestic violence, narcissistic abuse leading to separation of relationships that end up in family courts, and victims often being re-victimized by the court system. And, you know, that all of that is involved with that.
Yeah, absolutely. How about you, Cindy? What do you see?
I see fear. Their first reaction is fear, and that goes for everybody, because nobody wants to know or admit, I have a problem, or I can handle this, I'm not strong. What will people think? Somebody can come back to work with a cast on their leg, with a broken leg, and everybody wants to sign it. Somebody comes back from rehab or mental health treatment, they're afraid to talk to them. Well, are they okay? Are they gonna be okay? And quite honestly, they're usually the ones that are okay. It's everybody else that's refusing to go get out that they work with. But I see and hear fear, because I don't want to know I have a problem, because I can handle it. I'm doing okay. I'm all right. I'm fine. Right, Eric? I'm fine. Right, Tammy? And what happens is what are they going to tell me? Because everything I've feared, if you've got problems, we know we got problems. We just don't want to address it until it hits us right between the eyes. But now I'm going to be told, you have PTSD. Well, I'm not crazy. It doesn't mean you're crazy. And, well, I'm not taking the medication. Well, you didn't ask for the trauma, but you're responsible for your reactions, especially if your behavior is abusing family members. And so I hear fear. And how do you reduce that fear? And that's through education. That's through that peer. That's through what these people do. You know, it's just a title. It's just explaining why you feel this way. And how you feel is how you think, and how you think is how you feel. And then you kind of try to minimize that and let them know you're going to be okay. We just got to get you to the other side. We can do the easy or the hard way. But I see fear. That's the biggest factor I have that I need to work through before I can even get them to people like Tammy or Eric.
So you want to combat that fear, but help guide that journey, right?
Right.
How about you, Eric? When I say stigma in relation to PTSD, what do you think?
I agree with both you guys, and and Cindy with the, when that stigma is fear, and that equals silence eventually for a lot of people. And there's different layers to that fear that surrounds that. It's, what will my spouse think of me? For instance, my brother's a state trooper and he's a combat vet, and his big thing was like, I don't want that label because I don't want them to take my ability to do my job away. So I just can't talk about it. I don't want to be looked at as weak. I don't want to be looked at as someone that needs to be sidelined or benched. I can do my job. And, speaking from my own experience, a lot of us put this invisible line out ahead of us of, I'm not at this place yet, so I don't need help yet, right? It's like, I still have a job. I still have my house. I still have my wife. I'm doing okay, right? When I lose those things, that's when I'll go get help. And then, you start to lose those things. It's like, okay, it's time to move the goalpost once again.
Yes.
As far out as I can make it until I'm too uncomfortable to continue dealing with this. And again, a lot of that is just all stigma driven, because it's no secret that the world does view people with the PTSD next to them that as a lot of times even violent or dangerous. The court system does this constantly. I've gone to court with a ton of different veterans. I've been through that system myself, and PTSD is not really the diagnosis you want all the time, because there's a certain level of understanding that they have about what that could potentially mean. And so a lot of us just try to hide it, cover it up, deal with it, mask it, right? Drugs, alcohol, risky behaviors, whatever I have to do to make it so that I don't actually have to deal with this problem. And hopefully it'll go away on its own, is like a lot of the way people think, right?
Right.
We all know that that's not true. The problem typically metastasizes, beneath the skin. So I think it's the stigma is super damaging to people. And there's not a lot of education on this topic, right? There's not a lot of things like we're doing right now, getting people to understand like what exactly is PTSD. Not everybody with PTSD is violent. In fact, for the most part, the vets that I see, they're conflict avoidant. They're not even combative. They're trying as hard as they can to seek out peace and safety. So I think it's far more rare to have someone that is combative or dangerous or violent with PTSD than it is to have someone that's like, I just want to be left alone. So,
and one of the things, Eric, that you're talking about too is that PTSD diagnosis, and I'm sure Tammy would agree with me, PTSD diagnosis they'll accept over bipolar, because they'll say, okay, I'd rather be PTSD than bipolar, because sometimes these symptoms can be very indicative of different things, and that's why the assessment process is so important. And so when you look at the stigma, a good friend of mine was an officer and lost his ability to do his job because his department, if you sought mental health, isn't this sad? You seek mental health, you can't carry a gun, and now your career it's now changed. But what are employers doing that can help? What are they doing when they know something's wrong? What do they do about it except for say, hey, this happened? And when he talks about his stigma, it took his SWAT team to take him to the hospital when he was suicidal. He uses the word hope. Hang on, pain ends. And so sometimes we work on how do we instill, there's still hope. I know you've lost everything, but you're still here and you're still breathing. And now our job is, how do we find them to find their hope, understanding that you're far better off where you are now than where you're heading.
Absolutely. And I think that leads way to my next question. I do want to pull a question from the crowd here about what are some things that you may not want to say to trauma survivors? Or, what are some things that maybe you may not want to say to someone who, in support of their PTSD? What do you guys think? I'm going to start with Eric.
I mean, there's obviously a number of things. I know one of the things we really work on is not being judgmental and not trying to place the blame on the victim for the things that have happened to them, which does happen, unfortunately. It's one of those things of like, you're trying to identify with what's going on and get the situation together. And a lot of people, when they are trying to help people suffering with PTSD, is, people go into problem solving mode of like, let me tell you what I think or how you should do or you should act or where you should go. And it's without ever actually listening to the person. I personally went through this with my own family where it was like, you guys all have some plan for what I need, right? But nobody's listening to anything I'm saying. And it's like, I think it would be better for people, instead of really saying things, to just listen so that the person that they're trying to help feels heard first. And it's like, kind of asking them like, what in a perfect world, what would you do next? You know what I mean? What can I help you with? How can I get you to where you need to go, instead of telling people how they need to get there? I think I shrunk back from getting myself help a lot of times because of situations similar to that, and it's, or another thing I see people famously do is listing off all the reasons that you have to not be that, to change things or not be that way, especially dealing with people that are suicidal. It's like, it's listing off all the reasons that they should stay alive. And it's like, that's not really all that helpful. They're aware of the things they have to live for, but they're still here. So, it's kind of like, what can we do next to get you the help you need?
Right. No, thank you so much, Eric. How about you, Cindy?
I think sometimes in my field, because they're so tough, nobody can be real, nobody can be honest, they're not even allowed to cry, suck it up. That's overused. That's an excuse for your behavior because people don't understand, especially families, because I don't want to tell people that my husband or my wife is crazy, or, you don't want people to know that. But so you look at what people say to those people and their responses. And like Eric said, you got to meet them halfway to where they're going to be at. Because unless they feel, you can have as many letters next to your name, but unless they feel safe, it's been brought up a couple times, that they feel that they can trust you and that you care about what's happening to them without the judgment and the criticism, because it's not a life sentence. It's not a life sentence to have PTSD. So some cases can be very difficult because I don't want to be labeled. I mean, if you walked into work, support women's breast cancer in a nice pink shirt, everybody's like, yeah, that's really cool. You walk into work with a t-shirt that says, I'm bipolar, there's a difference. And we do treat it differently because people are afraid. Like, oh, what are you going to do? Come out of your skin and become violent, like Eric said. That's not the case. And they're just like everybody else. And this can be very easily managed with their cooperation. And they can have normal lives, and if there's glitches, they understand, they go back. But then move forward with the support of the people who respect and understand them.
Yeah. No, it's well said, Cindy. How about you, Tammy?
One thing that I feel should never be said is, what's wrong with you? It's what happened to you.
Yeah.
Not what's wrong with you, because that does not foster emotional safety. That does not foster the ability to build trust with the person you're talking to. Never saying the word crazy. People use that word way too much. In my opinion, I shy away from that word at all costs. Even nobody asks for trauma. Nobody asks for mental illness. Even a diagnosis as severe as schizophrenia, right? that person didn't ask for that, and they're not crazy, they have an illness, and those symptoms cause XYZ. If you took those symptoms away, they would just be who they are.
You're giving that person this opportunity to tell their story again, going back to that storytelling discussion we had a few minutes ago. You're opening up that door. We talked a lot about family members, friends, and coworkers, and it kind of leads way to my next question. So what does support look like from family members, friends, coworkers, or community members when someone is living with PTSD? So again, what does support look like from family members, friends, coworkers, or community members when someone is living with PTSD? So I'm going to start with Cindy.
The support is basically acceptance. I accept you. And sometimes communicating and saying, what exactly is this? Oh, okay. Because people don't openly say, oh, by the way, I'm bipolar. What does that mean? Are you going to like hit me, kill me? Is your head going to spin? And again, the education. Sometimes even having a candid conversation. Really? Well, what is that? Oh, well, you know what? I'm sorry. I'm glad you're getting the help that you need. I'm here for you. As opposed to people who may ridicule or make fun of. And it happens. But looking at how can we help you? Do we need to change schedules? Do we need to change time frames? You're not a morning person, you're more an afternoon person. If there's that flexibility in the job that they can look at, because these are valuable people who do a valuable job for them, who are managing something, and most of us don't even understand how many of the rest of them have stuff that aren't managing it appropriately. They're just afraid, to mention or to tell people what they're going through. So the support, I think, whatever organization they're in, working, and at home, education and support for families. How do I diffuse a situation rather than make it worse? How do we know when to let him go and let him be? And how do we know when we're going to try to encourage to, so it's kind of a balance that they learn and how to do that. And that's the support they get. And who can I call when I need help? Who do I call for the family program to say, I'm going crazy. He's just uncontrollable this week. Okay, tell me, because you can't say to him, you don't provide me with support. But he can't even support himself. So it's like making sure that on all levels, and even kids respond and react differently too. How do kids cope with this? And trying at 10, 12 years old, why daddy stays in a room all day and doesn't come out and play baseball? Because my friend Joey's father does that.
So making sure that everyone has their own set of supports, and we're kind of tapping into that as well. So how about you, Tammy? What do you think?
Well, I think most of what Cindy said is spot on, and safety is the word that comes to my mind.
Yes.
That's what it's all about for most, every human. Safety is paramount, I always say, whether it's emotional safety, obviously physical safety. So asking your person, was family member or friend, whoever it is, what do you need right now? What can I do? Can I do anything? Sometimes it's simply just being present and sitting next to them. Asking, can I don't know, example, partners, let's say, can I hold your hand? Is that okay? Can I give you a hug? Asking them first rather than just doing, with good intentions a lot of times, but good intentions sometimes end up re-traumatizing someone or setting off triggers because that feels unsafe, possibly, depending on what they experienced.
Yeah, absolutely. I was saying too, like we build space, within the confines of this virtual room here, but in many different pockets in the community, right? How about you, Ark?
I agree with both of you guys. I know, Cindy, you said first off acceptance, and I'd follow that up with patience and consistency, being there, listening. I'm not going to force out details. I'm going to respect your boundaries if you set them. And, I'm going to not take every single thing you do personally. I'm going to work not to, and it's hard to do as a family member, someone that's invested, or as a partner or spouse or whatever, like not to take the actions of that person personally, and it's like, it's not always necessarily about you. It's just the person struggling. And so I think another big component to that is education. If someone in my family or my spouse is dealing with something like that, I think some of the best thing you could do is educate yourself on it, right? Listen to other people's stories that have gone through this same thing. Talk to other family members that have dealt with that, right? I think you guys both mentioned kind of like make sure that support system's in place so that you're not drowning with them, and you're able to keep your head above water and know when it's time for you to back out. And, I tell people too, like, encourage treatment as best you can. But it's up to them, it's their recovery journey, and, and set your boundaries too, have your own boundaries of like, this is what's acceptable and this is what's not. Reasons are not excuses. So, you got to be mindful of like where you're at and what, I think Tammy said, like, safety's paramount in dealing with that situation or any situation like that. So, and that's pretty much it.
Yeah. And again, I do want to acknowledge there's some amazing questions coming in through the chat. We just may not have time to get to all of them, but hopefully we can find a way to connect with you and get you those answers. Again, thank you for all the questions that you're putting in the chat. But I do want to end, as we have a couple minutes left, with this question here. What gives you all hope that attitudes towards PTSD are improving? And what message would you like every person to hear about PTSD? So again, what gives you hope that attitudes towards PTSD are improving? And what message would you like every person to hear about PTSD? I'm going to start with you, Eric.
What gives me hope is the continued seeking of help from people. We have a long list to get in here. We have a waiting list. We have a lot of outpatient. And I think in general, I would like to say that mental health as a whole is kind of being brought in and open up, and people are less, they're more apt to talk about things. It's a little bit more of a comfortable atmosphere, even between when I got out of the military and now, you know what I mean? Like, being in service prior, it was like one of those things like, you don't talk about this, right? And I mentioned, like, you'll get benched, and it's like, coming out, I know the military has made some big strides in, making people feel comfortable as best they can to talk about things. I think Cindy mentioned, like, employers are doing what they can, or at least working towards doing what they can to make it more comfortable for people. Like, hey, you can have PTSD and we're not going to take your side, and we're not going to take your job. We just need you to go get help first. And so that it's not such a stigmatized thing. And, I think mental health is becoming more of a talked about topic. And there's positive and negatives to that, that have its own thing. But, and honestly, like, it's not a life sentence thing, you know what I mean? And it's like, I think people really need to understand that, like, just because you have a diagnosis does not mean it's forever. It doesn't mean that you're damaged goods, you're malfunctioning. And that's not the case. It's just like, my nervous system, so like rewiring itself to handle this and do its best to survive. And that's, it's doing what it can, but there's help out there for it, and I don't have to deal with this forever.
Yeah, no, absolutely. How about you, Tammy?
I think what we're doing right now gives me hope.
Yes.
Getting education out there. I think there's still a lot of work to do. But there's conversations in schools, workplaces, healthcare settings. But the idea that it's more and more talked about is hopeful. I'd like to see more collaboration among various settings in educating everyone. including other professionals. I wanted to add in before we ended today about, all of us, even as professionals, making sure we're taken care of and we have our own safety, our own therapy. If someone said to me one time, well, you're a therapist, why would you need a therapist? Well, we listen to a lot of things. We take on a lot of other people's trauma. There's something, and plus we have our own lives and stories to go with it, right? But we can suffer vicarious trauma by doing the work we do. So it's important to always be taking care of ourselves as well. And, I think there's stigma even around that. Well, you're a professional, why would you need help?
Yeah, no, that's well said. I know we're at 1 o'clock. I want to be mindful of time, but I want to give you an opportunity to Cindy to wrap us up here.
I agree with everybody. This is a start in an ongoing collaborative approach that we all use, number one. Number two, what gives me hope is this: is every time the phone rings, every time somebody reaches out, I get hope. And someone out there termed that statement, it's okay not to be okay. And you're human, and there's people like us who care and are available to you at any time.
Amazing. And this was the fastest hour I think that I ever had with a panel before. You all did an amazing job. I'd like to thank again Cindy Goss, Eric Krupczyk, and Tammy Kling. I also still thank everyone behind the scenes. So Mike Telesco from Telesco Creative and everyone on the Erie County Anti-Stigma Coalition Outreach Committee. Keep a lookout in the future for our future Facebook Lives. And if you join us late or want to tell anyone about this episode, all of the Facebook Live events will be available on the website, letstalkstigma.org, right at the bottom there. So together, we can reduce stigma and create safe environments in our communities. So on behalf of the Anti-Stigma Coalition, thank you all for listening today.
Thank you. God bless.
Thank you.